Thank you. This is a very brief overview of the role of exercise in motor neurone disease. It's a very common question that physios are asked. What role does exercise play in the management of this disease? Should I rest or should I exercise? What sort of exercise should I do? How much should I be doing? Unfortunately, despite muscle weakness being one of the most widespread clinical symptoms of the disease, there's a complete lack of randomised controlled studies into the effects of exercise on motor neurone disease. Some of the challenges that the researchers face include, we've discussed this earlier on today, the heterogeneity of MND, so patients present very differently depending on what sort of MND they've got, what muscles are involved. They've noticed high dropout rates of clients. The rapid deterioration of patients also makes gathering data difficult. Demographics, so that can be hard in getting patients to join studies as well as retaining them, and also funding, which hopefully is on the upward trend now. However, some small studies have shown that there have been benefits in terms of a slowing in deterioration of ADL function in patients that have participated in aerobic exercise compared to control groups who have done just passive exercising. So despite not knowing exactly the role of if exercise does slow down the progression of MND, we still know that there are many known benefits. So exercise can help decrease in disuse atrophy and deconditioning. So we can't stop the cause of it, but we can help reduce secondary weakness through inactivity. We can work on non-affected muscle groups. We know that exercise has psychological benefits, so exercise increases the release of endorphins, which is mood enhancing. So for that reason, we all know that low mood is common in patients with ALS. And also, as we were talking about before, it gives them hope. Gives them a bit of control over their disease, a bit of something to fight for. Exercise may lower spasticity. We know it maintains flexibility in soft tissue and joints, prevents joint stiffness, particularly in the upper limbs where adhesive capsulitis is quite common in these patients. Improves circulation, and as Carmen was saying before, it helps with pain. So how should exercise be prescribed? So I have put this into a staged approach, but this is basically on the symptoms that they present with, irrespective of what kind of ALS they have, what kind of motor neurone disease they have. So in the early stages, it is important to be referred to a physio as soon as possible after diagnosis if exercise is something that the patient really wants to engage in. In the early stages, they may be fully independent and with maybe just localised focal motor loss. So with patients in the early stages, current best thoughts are low resistance, moderate intensity, enough to get a physiological response such as an increased heart rate. This is all based on clinical opinion rather than the data that we were saying is so lacking. If their mobility is good, I would recommend a walking program. The use of exercise bikes, reciprocal pulleys, upper limb and lower limb exercises, and hydrotherapy may be beneficial as well. So as we were saying before, a lot of them do have pain from other musculoskeletal issues. Hydrotherapy is a great medium to stretch in, but we do need to be mindful, A, of the fatigue that the warm water can cause, and also for any patients that have respiratory muscle weakness, the effects of the raised intrathoracic pressure on the muscles needs to be looked at. So in the mid stages, the patients may be presenting with falls. They may be requiring walking aids, and it's sort of in the middle stages that you notice the upper motor neuron clinical signs like hyperreflexia and spasticity are really coming into play. So it's if the walking is limited, or you consider them to be a falls risk, make your exercises a bit more functional. So even just practicing sit to stands, practicing transfers, practicing bed mobility, bridging, rolling, that sort of thing. Have a look at their muscle length. As I was saying, muscle shortening occurs, and we need to keep an eye on that, whether it's adding some stretching to their exercise program. Always look at the safety of the environment, if you think they are going to actually be able to carry out what you want them to do in a safe manner, because we know they're already at high risk of fall and we don't want to make that higher. And looking at spasticity management, a lot of the consultants will have these patients on, I've completely forgotten, not baclofen, gabapentin. So if you're treating them and you find that perhaps they have a sudden loss in their ability to sit to stand or transfer, just have a look if their gabapentin has been increased, because sometimes that's enough just to make them, if they've had too much, it can really have an impact on their ADLs. In the same sense, if you feel that they've got a lot of strength but a lot of overriding spasticity, it may be a good idea just to consult with the neurologist and say, look, I think this patient is actually quite strong, but spasticity is stopping us from doing what we want to do. In the later stages, as we have also discussed a bit earlier, the exercise regime becomes more passive or active assisted. Now that may be with physio, carer, family members. It's really important that they have an upper and lower limb stretching regime for comfort, pressure relief and pain. And we were talking a bit earlier about videoing things. Often I will take the patient's family member's iPhone and we'll just film the correct way to manually handle the supporting of the joints, so they've got it at home to look at for a carer or another family member. And I also, if in these later stages when they normally are wheelchair bound, I educate on correct seating positions for spasticity, for pressure, and for the optimal position for the respiratory muscles. So, in summary, general considerations when looking at an exercise program for a patient: try and make the exercise program functional and individual. So we really want them to try and comply. If you've just given them a generic list of exercises, compliance will be lower. Review the exercises frequently to prevent demotivation. Really important that the intensity of the exercise that you're giving them should not compromise their ability to carry out their ADLs. So if the carer or the patient reports that after physio the next day they can't do this, they can't do that, you really need to cut back what you're doing. And that's where we need to be educating on energy conservation as well. Talking about the frontoparietal dementia, it is really important, even with people that you think are quite sensible, practical, reiterate that exercise is not going to improve strength in their affected muscles, that the aim of our physio intervention is really to be as good as you can be for as long as you can be. Thank you.